Welcome to the Coming Home Well podcast, the show that educates, supports, and advocates for the veteran community. Your host, Dr. Tyler Piron, U.S. Army retired, will bring you exciting conversations with amazing guests about resources, research, and military history, all geared to helping our warriors to come home well. Here's your host, Dr. Tyler Piron.
Welcome back to Coming Home Well. I'm your host, Tyler Piron, and today we are going to talk about one of the most serious subjects that we talk about as veterans. It's suicide. And in order to sort of get a better understanding of the resources out there and some of the statistics and some of the actual information, because we hear a lot of things from a lot of people, and some of them have agendas, some of them are not being completely honest. And other times, there's people that are just trying to raise some money to get attention, and they sort of over-talk it and sometimes under-talk it. But suicide is one of the most significant concerns, especially for folks who have deployed. But you don't have to have deployed to be a suicide risk, especially in the veteran community. To help us talk about this and sort of get a better understanding of where we're at, we have a licensed clinical social worker. She's with the Hampton VA, which is down towards the Virginia Beach area, and we are very glad to have her on. Her name is Megan Flaherty. She's a licensed clinical social worker. Thank you so much for joining us on Coming Home Well.
Thank you so much. I really appreciate you having me here to talk about this topic. It's really important that we continue the conversation and just talk about the reality of what's happening.
So what is happening?
Well, a lot. So we have suicide is actually the VA's top clinical priority. And so the VA is dedicating a lot of time, energy, resources, and effort into really addressing suicide prevention with the public health approach. So kind of shadowing what the CDC says, which is this is not just something that our mental health providers need to be talking about. This is something that we need everybody to be talking about and continuing that conversation. So within the VA system, we have virtually any clinician who meets with veterans, our frontline staff, anybody who comes in contact with veterans has regular suicide prevention trainings to really know what to do and what to look for and how to respond if there is a crisis.
You know, I was just at my doctor's. I was having a physical, and they went through this checklist. Are you suicidal? Are you drinking too much? Is that part of what you're getting at?
Yeah, so that is what they call the universal screening. So we certainly do kind of targeted screening for specific populations and specific situations, like maybe during a mental health intake, there's some policies around making sure we screen for specific things in those intakes. But really, this public health approach means we ask everybody, how are you feeling? How are things going? Have you been having thoughts of depression or feeling depressed? Have you been having thoughts of self-harm? And it's really intended to capture the folks that maybe wouldn't necessarily come out with that, or maybe has been having those thoughts, but isn't necessarily willing to volunteer it, so to speak. And so it kind of helps build the rapport with their providers as well, because that's showing that your primary care doctor does care enough to ask you about your mental health, not just to check your blood pressure and not just to check on your insulin, but to really ask the big questions, because you are a whole person and we want to treat the whole person.
So what is the public health approach, or what is the alternative to the public health approach?
Yeah. So, I've been in the field for going on 20 years, but I've been at the VA I've been federal for 15, 2 years at DOD at Fort Belvoir, but otherwise with the VA. And a long time ago, mental health questions and treatment and approaches were really intended to be addressed by the mental health providers. But that wasn't broad enough. We were still losing too many people every single day, and we still are. One is certainly too many. But so we broadened this approach, and so we have virtually everybody talking about it and asking about it. So making sure that we, talk to radiology, making sure we talk to the dental clinic, and making sure that those folks are well trained and versed in what to look for and how to ask. So I do think the general population wants to help. They just don't necessarily know how. And so VA has really kind of spearheaded the efforts to make sure everybody's trained and knows what to look for.
So folks are looking for these signs, or they're asking, and it's always amazed me, and it's sort of counterintuitive. But if someone is suicidal, Are they willing to fess up to it, so to speak?
Yeah, I think as long as the person who's asking comes across genuinely and empathically and not as though they're checking a box, right? We don't want people to feel like they're just a number, we're just checking a box. We really want to plug in and make sure that they're getting their needs addressed. So if somebody does come in and they're suicidal, we want to be comfortable asking that question, but we also want to be comfortable knowing what to do next, right? Because people do want to help, but sometimes they're scared. What if they say, yes, I am suicidal? Oh my gosh, then what? So really the idea is to kind of empower those providers so that they know what to do if and when somebody does say yes, because it will happen at some point. You will, if you screen everybody that comes through your medical practice or your mental health clinic, at some point somebody's going to say yes, right? That's just the nature of it. And so it's important that that person knows what to do when they get that yes response.
I guess that would be a kind of a freaky thing if, you like, yeah, I was actually thinking about killing myself today.
Mhm.
And they're like, crap, I don't know what to do.
Yes. Yeah, it can be very intimidating. And your blood pressure goes up and you start to think, oh my gosh, who can I call? What can I do? Many years ago when I was first getting into the field, it was I'm going to date myself here, but it was pre-Skype, text message, that kind of thing. And so I had somebody in crisis on the phone and I quite literally took my shoe off and threw it into the hallway to get somebody's attention. We don't have to do that anymore, right? We work in teams, so we can message somebody and say, hey, I need some help. And the key there is to rally the support that you have around you, whether that's within your own kind of internal team or even using the Veterans Crisis Line or the National Crisis Line.
So if someone's at the VA and they say, yes, I've been thinking, I've been very depressed. I do want to kill myself. What happens?
Yeah. So I tend to think of suicidality as being on a spectrum. Okay. So you might have on one side of the spectrum somebody who has a really high functioning depression, wakes up in the morning and wishes that they didn't wake up in the morning, but still goes to work and still takes care of their family and doesn't necessarily have a plan. Right. On the other end of that spectrum, you have somebody who is acutely suicidal with a firearm loaded in hand, in their car, in their bedroom, on a bridge. And then you have everything in between. And so it's hard to say what happens when they say yes, because it really depends on where they fall in that spectrum. But I hope that offers reassurance that it's okay to tell your providers, yes, I am having these thoughts, because it doesn't necessarily mean we're going to call the police and send the police to your house and you're going to go to the hospital. It might mean that we need to make some medication adjustments or create a safety plan or get your family involved and just let your spouse or your partner know that, hey, can you keep an eye on him for a couple days just until the dust kind of settles? So it really depends on where they fall on that spectrum. The response from your providers is really going to vary depending on that, where it falls on that spectrum.
So it's a tailored approach. It's not a down the checklist. Oh, they said yes. So I see subpart B, which says A, B, and C, D. It's really a spectrum of responses based on the spectrum of where you are at the time.
Yeah, and it really depends on the level of acuity and, do they have a plan? If somebody living in Virginia Beach says, I have a plan, I'm going to jump off the Empire State Building, but they don't live anywhere near that and they don't have the means to get there, then it's, they still could potentially do something, but that specific plan is maybe not so feasible at the moment. But I really want to take a moment to make sure that we talk about firearm safety too, because not in the interest of, infringing on any rights or anything like that, but just firearms are so potentially lethal that whenever we're talking about firearms in the context of suicide, that kind of raises the stakes for everybody. About 90% of attempts with a firearm are fatal.
And how many attempts? I'm sure there's a number of ways people try to hurt themselves. I've seen a bunch overdosing on various things or firearms or hanging. And I was a CID agent. I was a criminal investigator. We went to every death in the whole Metro DC area and lots of other places I was assigned. So I've seen lots of ways that people have hurt themselves. But how does it work out with veterans and suicide? Is it mostly firearms? Is it mostly hanging or car accidents? Or what is the numbers these days?
Yeah, that's a great question. It's firearms. So about 70% of suicides between 2019 and 2020 in the veteran population were by firearm. And again, that's because the method itself is so potentially lethal. We're saying about 8% of suicides were by poisoning. Somewhere between 16 and around 15% was the suffocation was the method. But generally speaking, firearms, we talk a lot about firearms because the method is so potentially lethal. And if we can get folks to kind of work through that immediate phase of crisis, if you think of crisis as kind of being on a bell curve, if we can get them through the top of that bell curve and onto the other side, the risk for suicide is significantly decreased. So safe storage of firearms, particularly when they're in the top part of that bell curve, is really critical.
So when people are in crisis and they're like, yeah, I'm drunk, I'm drunk as a skunk, I've got a gun and I do something maybe impulsively, they're very successful at it, unfortunately. Is that sort of like the way it works?
Yeah, so just maybe a nuance. We try not to refer to as being successful because no suicide is successful, right? I mean,
Fair.
we don't want folks to think that that's the end goal. But if somebody is drinking, their inhibitions are lowered, right? There's a reason people talk about crying in their beers. So their inhibitions are lowered. Alcohol is a depressant, so it's going to make them feel more depressed. And so they're more depressed and more impulsive. And so if they have a loaded firearm with them, and they're having the suicidal thoughts, the risk for suicide is dramatically increased.
So is one of the safest things, if you are or you're around a veteran, making sure that there's some access control to the firearms, put the guns in a safe, keep the ammunition not loaded in the gun, those type of things? Are those fairly effective measures for that immediate crisis period?
Yeah, those are all great ideas. I love them. So we call it in the VA, and I think the larger system, they call it lethal means safety. So it's really anything that creates time and space in between the thought to harm oneself and the ability to access the means or the method. So VA can pass out gun locks. They're cable locks that go through the chamber with a little padlock on the end, has the crisis line number printed on it. And it comes with 2 keys. So that's a lethal means safety intervention. And one of the trainings that I was in, one of my veterans said, well, yeah, but I can cut through that with a bolt cutter. And I'm like, right, you can. But in the 10 minutes that it's going to take you to get your bolt cutters out, your mom might call or your brother might stop by. And that's creating that time and that space. So certainly we can distribute free gun locks to any veteran or their family member who needs one, or more. If you need more than one, that's fine.
Most veterans I know that have guns have way more than one.
Right.
So.
Yes. So we can get you as many as you need, but also, maybe giving the key to somebody else until the crisis has passed. For medication, we do talk about medications too. So maybe limiting the number of pills you get in a refill, or having somebody set up a pill box for you and then they hold on to the rest of the pills for you, and just until the crisis passes. These are not things that have to be in place forever, but they are things that create that time and that space.
So the folks, and we've heard the number 22 a day forever. Is that still accurate?
So according to the last 2022 National Suicide Prevention Annual Report, that number is at 16.8 per day. And that comes from VA's data collection, comes from the CDC and the National Death Index. And so we know how that data was collected and where it came from. But 16.8, 22, one is too many. So, we really try to emphasize that it's good that the numbers are trending down, but we still have a lot more work to do.
Obviously, I mean, 16, 17, 22, they're all way too many, especially a day. But the trend line is down, which is good. I mean, some of these interventions are working. Is that the right thing to take away, that if you ask for help, it's going to help?
Yeah. And again, just kind of identifying that we are more than just a diagnosis. We are more than just a medication. We are people that have, certainly we've been through a pandemic, lots of influencing factors. And so, VA has moved towards this new role or position or program that I'm in, this community engagement and partnership coordinator position. We work side by side with the suicide prevention team. And the beautiful thing about this program is that we, of course, are working towards, connecting with and saving our veterans. but we also can work with the service members, veterans, families, the community at large. So it's no longer this role doesn't have us just within the hospital, the bounds of the hospital. It's really out in the community because that's where the veterans are living. That's where they're interacting with their family. That's where they're going to work. And so the CEPC role is really focused on improving the environment and the community itself, not just saying, "Hey, are you having suicidal thoughts?" Those are important things to do. Gun locks are critical to the efforts, but it's really a broader approach to working with the entire community at large.
So let's talk about that community engagement part, because that is something that's relatively new
Mhm,
in the scheme of VA stuff.
mhm.
Obviously, we have community-based outpatient clinics. I go to one. We were talking earlier, and I was saying that I have had the same doctor since 2009. Dr. Holmes, if you're listening, you're great. Appreciate you. But there's a lot more that's being pushed out to the community, and a lot more resources outside of my local hospital is in Richmond. You're down in Hampton. Obviously, the big hospitals have a lot more resources, but they're realizing there's a lot of people, a lot of veterans that are not in that immediate catchment area. And driving 2 hours to get to the VA is just like too much.
Mhm.
So, how is this community engagement different? Like, what are you doing? Are you visiting folks, or is there at the clinics? What does that look like?
Yeah, so my role specifically, the CPC role, is it's an administrative position. It's not a clinical position. Um, but we work with the community members who are working with our veterans and their families. So the public school system, right? A lot of the kids are dealing with PCSs, and mom's gone, dad's gone. Now we're moving to another state, and just helping the school system better understand these are the special needs that this particular population of kids have. How is your military cultural competence? Do you understand what it means when the kid says, when the child says, "Hey, I have to move again," because this is his fourth move in 2 years, and the impact of that. So it's the school system, it's the active duty side. I'm doing a lot of work with DoD and supporting those men and women, and they certainly are dealing with their own suicide specific challenges there too. Um, and it's
Heartbreaking.
really it really is. It is. And there's so much work to be done. In Virginia, we have such a high military active duty population in this area. I believe it's the second highest in the country. So there's a lot of work to be done there too. And they're ready, willing, and able to do it, but they need the resources and support. And that's where the CEPC comes in, and the suicide prevention team.
So it's adding another layer sort of in between the hospital and the physician, and also working with the schools and all the other places that the military family and veteran families are interacting with. So they can say, hey, these are the sort of the things to look out for, or unique requirements.
Yeah, so as a CPC, we go to the community and say, what are your needs? Where are the gaps? You tell us, because I know what's happening in my cul-de-sac, right? But I don't know what's happening over on your side of the tunnel. So we ask the community to give us input on what's working, what's not, and then we help kind of mobilize the coalition work to meet those needs. And all of it, the work belongs to the community. It's driven by the community and their needs, because I may think that they need X, but they actually need A. So what I would bring is not relevant because they need A. And so I help them get that particular target met. And so it's really meeting the community where they are, because that's where the veterans are, that's where their families are, and we want to meet them out in the community itself.
No, that makes perfect sense. It's a very insightful method of sort of projecting power. I think most of our military folks would understand that. You can't do it from behind the brick walls. You got to go out and project that power, and that ability to go out and reach folks. So I am kind of curious, what is it, the demographics? And really, it's a risk question. Who's most at risk of attempting suicide?
Yeah. So 18 to 34-year-olds is really the highest age group. And then Caucasian or white individuals as well. Those are the highest age groups. But we know that the Asian, Native Hawaiian, Pacific Islanders, and the American Indian, Alaskan Natives, that group of the population is also trending in a concerning direction. And so we really need to make sure that we're reaching out to those particular age groups and race groups that are affected by suicide. There's a lot of work to be done there too.
18 to 34. That it surprises me. I mean, I'm no expert on the statistics, but yeah, obviously I was thinking like 18 to 25. But as you get older, does the risk decline significantly, or is it sort of just a tapering off?
Yeah. So it starts to decline after 34, and then at around 75 it starts to go back up. Um,
Ah,
yeah, which is very interesting. I think a lot of people don't think that's the case. I think because there's an assumption that you're older, things have settled, you're probably retired at 75, goodness hope so, and kind of enjoying life. But the reality is that's the age group that's it's going up. So we need to make sure that we're reaching out to our older veterans, especially the ones who live in kind of rural areas where there's not a lot of resources, and make sure that they have the support that they need as well.
and that's just generally good advice, especially folks that are more isolated, not connected with other groups, and being out in the country can certainly accentuate that.
Mhm.
So, have you noticed, or do you know? And I don't want to play trick questions. Is there differences in the different eras, the World War II, Korea, Vietnam, Gulf War, uh, 9/11 veterans? Is there different cohorts that have different risk, or is it sort of based on age more primarily?
Yeah, I think that's a great question. I think that the 75 and older speaks to the veterans who served during those war eras, and 18 to 34 is, of course, our post 9/11 veterans. And so I think it's specific. It's reflected in the age group specifically.
Okay. Yeah, just curious, because it's obviously the number of folks, and you've also got different, I don't know, cultural norms and
Mhm.
sort of just the ability to ask for help. One of the things that I'm always amazed at is the younger population. I don't even know what they call millennials now. Maybe young millennials, the Gen X,
I don't
whatever
know. It's not me.
the current 18 to 24-year-olds are in a different group, and they're seemingly, based on my interactions, much more likely to go get help, and there's no stigma or very little stigma compared to the past to go and say, hey, yeah, I see a therapist and I'm on meds and I'm feeling much better as a result. I
Mhm.
see that way more with the younger folks than I've ever seen in the past. Before, it was obviously some stigma. I don't know if it's all age groups. Do you see that as well, that some groups are much more willing to get help?
I see that. I see the culture shift in general, right? And I honestly think that the public health approach is driving that to some degree. It takes a while, right, to shift an entire culture's perception of mental health and to reduce stigma in seeking help. That's not an overnight process, right? But if you go to your doctor and your doctor's asking about it, so you're having the conversations with your doctor, and then maybe you mention it to your friend, and your friend thinks, oh, well, so they said that they were a little depressed. Well, I kind of am too. So it's normalizing the conversation. Even if the screening is negative, it's still normalizing the conversation. And I do see more of the younger, I have two young kids under the age of 13, and it's just not something that is dramatic. It's not something that's like, taboo to discuss anymore. The kids are just talking about it. And I think that's a beautiful thing.
Like, oh yeah, go get help and da da da, and I'm much better. Yeah, it is a
Yeah.
big shift for me. I mean, I see it, and it warms my heart because they're like, hey, there's people dealing with a lot of different challenges, and getting help is like the easiest way to deal with so many of these issues.
Yeah.
But hiding it and stuffing it down and not dealing with it, which is generally the least effective way, is not so much the thing anymore. So I was wondering, so we talked a little bit about this, and we were talking about these interventions and making sure that these resources are available, and medicine is evidence based. What does that mean?
It means that there's enough research to show that medication can be helpful, that therapy can be helpful. A lot of times, what we see is that the two combined really make the most impact. I understand people can sometimes get frustrated with medication because it's kind of a small target, right? It has to be the right medication, the right dose, right length of time. It's kind of a small target to hit. But if you work closely with your doctor and just have honest communication with them, you can hit that target. And then the therapy piece is really kind of reframing the way that people think about things. We have lots of automatic thoughts that are negative, usually anxiety inducing. And so using the medication to kind of help control the physiological piece of that while also using therapy to help you control or get better control over your thought process, that's the most impactful way to treat depression, anxiety, PTSD. But VA really pushes best practices and evidence-based treatments because we know that these things have been researched for a long period of time and that they work.
And that's the real key, isn't it? That they work. I remember looking at some of the studies on medications and like, oh, it really works. And it's like 50% of the time. And I was like, wow, that is just like, if I got a 50 on a test, I'm failing, right? But
Right.
but 100% of the time, or 50, what's the old movie saying? 60% of the time it works every time.
Yeah.
That's an old funny movie. But if you're in that cohort of where it works, it's awesome.
Mhm.
And if it doesn't, you just try something else.
Right. Right.
And
Yeah.
that's
And
important. It's not going to be a, failure most of the time.
no, and if you have somebody in your family who maybe did well with one particular medication, odds are good that you'll also respond to that medication. So again, reducing the stigma and having the family conversations about it. I did well on this medicine, so you might too, because we're related and just biologically things are kind of similar. So
Makes sense.
opening the door, just having more of those conversations.
So, as part of this entire approach that the VA is using, there must be some structure, some conceptualized idea of how the federal government, the states, the counties, the VA, and all these other resources sort of work together. Is there a way you could sort of layer that onion of how that works?
That's a big ask.
Well, I mean, in a big picture, I mean, you don't have to
Yeah.
go super detailed, but
Yeah. I mean, it's a big system, right? And I think for VA, the bottom line is we want our veterans to come to the VA, but if they don't want to come to the VA for whatever the reason is, we just want them to go wherever they feel most comfortable getting help. And that's where the CEPC role comes in because I can tell you that, I understand that you don't want to come to the VA, but here are your other resources that are available to you in your community. Please reach out to them. I'll give you the information. But we also do some work with the governor's challenge and making sure that we're working closely with those folks to on a state level to raise awareness and have those conversations. And we have really partnered kind of beautifully with them as well to make sure that that information is shared in a partnership that just works.
so part of that layering thing, and I've done a bunch of segments on veteran homelessness and justice involved veterans and all these other big stressors.
Mhm.
How does this fit into the suicide prevention? Does it as a component? Do you participate in those things? What does that look like?
Yeah, so I mean, I kind of have my finger in a million pots at the same time because
I
that's
imagined you did, so
I
that's why
do.
I asked the question.
I do. Because people need to know that we're out here and we're available to support their coalition efforts. So I'm working on a justice involved coalition. I'm doing, again, a fair amount of work with the DoD and trying to not only distribute gun locks to them, but also make sure that the service members know that there is a VA. I met a veteran or a service member the other day who didn't even know what the VA was. I thought, goodness gracious, we need to do better. Let me tell you about it. And so really partnering with them, but talking to the homeless shelters and making sure that the resources that they need are things that we can provide to them as well. So we talk sometimes about like social determinants of health. We talk about employment. We talk about food deserts. You name it. I'm interested in having those conversations.
All those additional stressors and all those things. So
Mhm.
let me ask you this. If you know a veteran and they're not involved with the VA at all, they never submitted a claim, they don't get health care from the VA, but they're struggling.
Mhm.
They're potentially suicidal, they have PTSD, fill in the blank, but you're worried about them and their mental health, and they're not involved with the VA, and you're their friend. What would you tell them?
Yeah. So I would tell them to, potentially depending on the situation, to probably go to the closest emergency room and have a conversation with that doctor. And it doesn't have to be the VA emergency room. So there was a new act that was released. It was a couple months ago. It was this year, called the PACT Act, and that means that VA will provide, pay for, or reimburse emergency care for certain veterans and individuals in a suicidal crisis. And that includes ambulance transportation costs, follow up inpatient or residential care related to the event for up to 30 days, and outpatient care for up to 90 days. So that's
Wow.
that's the
That's
Compact
a big
Act.
coverage. I mean,
It
because
is.
a lot of insurances, especially if you're young and don't have a full-time job, if you just get out, you don't have those resources.
Yeah, it's huge, and we want to make sure folks know that you don't have to wait for your DD 214 to show up to enroll so that you can go to the hospital. No, just go to the hospital. The big key here is going to be just letting the VA know within 72 hours of when you started that episode of care or treatment. That'll increase the likelihood of reimbursement. But please don't wait. You can even just call 988, the crisis line, and have them help you kind of work through what to do in that moment, kind of triaging the situation to see what makes the most sense.
So I do want to, what, tell us about 998, because we see it more. We've always talked about the VA number, the 1-800 number, but really 988 is like a kind of new,
Hmm.
not
Yeah.
super new, but kind of
Well,
new.
kind of, yeah. So July of last year, at the FCC rolled out 988. It doesn't replace the 1-800-273-8255. That is the regular national crisis line. It doesn't replace that number. It's almost like a supplement to that number. So anybody can call the 1-800 number or 988. If it's a service member or veteran, they press one, and that links them specifically to responders who are well versed, have lots of military cultural competence, are probably likely a veteran themselves. So can really have that conversation on that peer-to-peer level. You can also text the number. It's not 988. I'd have to look up the text number. You can also go to the website and just chat on the chat. But they have had a dramatic increase in phone calls, outreaches to the crisis line since the 988 number was released. And I think that's largely because if you think about, if you were in crisis, right? If you had the means in hand and we're going to do something like this, to hurt yourself, would you remember to call 1-800-273-8255?
No, of
Or is
course
it
not.
right? Yeah. And the only reason I know is because I've been doing this for so long. But you'd be more likely to call 988 and just be able to reach out right away.
Yeah, especially if you looked it up in advance. I can remember three numbers. Remembering a full-on 800 number is probably beyond my skills at that time.
Right.
But yeah, so that makes a lot of sense. I just wanted to harp on that a little bit because it's such a easy thing that's made such a dramatic difference in helping people get help when they need it.
Yep. Yep. For sure. For sure.
So I want to ask you a couple of questions. What got you into helping veterans? What does that path look like?
That's a great question. So I'm from the Midwest. My mom and stepmom are both teachers, but my dad worked at the VA in Illinois for almost 30 years. And so he would come home, telling HIPAA compliant stories about, being a social worker in the VA and what that was like. And I've always had a soft spot for mental health type support and services. And I think that it's important that we are supporting those who have served our country in the best way that we can. And I know for me that this is the best way that I can do that. So I started out in the community, but then I went to the VA in Chicago, Jesse Brown VA Medical Center, for a handful of years, and then Fort Belvoir. And then I've been here for coming up on 6 years.
Yeah, that's always amazing. I'm always curious, like, the sort of the background story and the origin story, like they talk about Batman and, think of Superman or the origin story. Like, what got you here? Because
Right.
sometimes it's, people served in the military and then they retired and transitioned, or they served a period of time, or and more, I especially outside of that specific area, it's an amazing mix of folks that are like, I just find it's more interesting, it's more, impactful. And you sort of talked about it. you grew up with it in a lot of ways, sort of, hey, I sort of understand this community.
Yeah. Yeah. I mean, all of my siblings, we're all kind of in helping type professions. And VA just kind of spoke to me. So, here in the area, my father-in-law is retired Navy captain. So he has lots of stories about, his experience in the Navy. And my husband certainly traveled around with being a Navy brat, his words, not mine. So, I mean, there's a lot of history here, and there's a lot of opportunity to help the active duty side.
So I asked you a lot of questions, but I'm sure there's something that I forgot. Is there something that I should have asked you but didn't?
Yeah, so I don't know if you're familiar with the PACT Act. Have you heard about that?
I have, but I haven't talked about it a lot.
Okay.
But yeah, we need to foot stomp it because the dates are coming up.
Yes, very good. So the PACT Act is a new law that expands VA healthcare and benefits for veterans exposed to burn pits, Agent Orange, and other toxic substances. So I really encourage folks to file an intent to file a claim or submit an intent to file a claim ahead of August 10th. If you do that, you may be able to get retroactive payments to August 10th when the PACT Act becomes law. So really encouraging folks. There's a lot of great information. I can send you some really great tools and QR codes and all sorts of fun stuff that just kind of gives you some guidance on what to do. But please, if anybody has been exposed or thinks that they were exposed or even potentially might have maybe sort of been exposed, go ahead and file an intent or submit an intent to file because you may be eligible for benefits just based on that.
That's a really good point, because if you're deployed to Iraq, Afghanistan, you were exposed to a bunch of nasty stuff. I guarantee you, I promise you, because everywhere had a burn pit. If you're in Kandahar with the big poo pit, if you were around fuel, if you were in Vietnam exposed to Agent Orange or Thailand and some of these other things, it greatly expands the number of conditions that are considered presumptive. And that's a really big deal, because if you have X, like, sinus problems or breathing problems, and you have Y, I served X, Y, and Z, the places that they say are covered, then you don't have to prove that your condition was caused. They just presume it, which is a much better way of proving that it's related, because it could be, in the Agent Orange, we're talking decades. If you were in early part of 2002, 2003, Iraq, Afghanistan, there weren't any records. I get it. It's not like they had every burn pit, marked on some map. It was just like, hey, that's what we're doing today. We're just getting rid of the trash and its batteries and chemicals and all sorts of junk. Everybody knows that was on one of those details or saw it, all the piles of trash and all those things. So definitely go file, definitely get that. Even if you don't need help today, getting that condition that you have documented. I always akin to a insurance policy. Yeah, veterans benefits are great and financial, all those things. But when you start getting 60, 70 years old and your health insurance costs skyrocket, and all of a sudden you've been having all sorts of new issues or cancer or whatever, the VA already has you covered because you filed years before it was an issue. So definitely go file. I think the PACT Act is definitely a recognition of the things that we all know, but they need to prove it, so to speak. It's the same thing with Agent Orange. Took forever to identify, hey, yeah, all these people have like these massive amounts of cancer. Weird.
Yeah.
Then they recognized it in law. And so a lot of times the VA's hands are tied as well. Without these studies, without these laws, they can't necessarily approve things based on supposition. But once they're able to do it, it's a big deal. I leave you with the last word, Megan. Thank you so much for coming on Coming Home Well and talking about a very serious subject. I'm really glad that we have lower numbers. I hope they continue to go down to zero. Every little bit of intervention helps. If you could leave everybody with one thing, what would it be?
Well, I would love for the numbers to continue to go down and work myself out of a job. So if we can do that, please do. I can find something else to do. But I think the key message here is, reach out. talk to your friends, talk to your family, talk to your people, talk about firearm safety and safe storage. If you want or need gun locks, please reach out to your local suicide prevention team at the VA. They will get you gun locks. Continue the conversation, because that's the only way those numbers are going to continue to trend down. And I really appreciate just the ongoing conversation here too. So thank you.
We've been talking with Megan Flaherty. She's a licensed clinical social worker at the Hampton VA on the coast, enjoying that beautiful time of year with the beaches and everything down in Virginia Beach and Hampton. It's a nice area. But thank you so much for coming on Coming Home Well and talking about this very serious and very important subject.
I appreciate it. Thank you.
Thanks for joining us this week on Coming Home Well with Dr. Tyler Piron. If you enjoyed this episode and you'd like to help support the podcast, please share it with others, post about it on social media, or leave a rating and a review. Thanks again. And until all are home and all are well, this is Coming Home Well.